Well, good morning, everyone. I'm John Schurrer, a senior researcher here at Mathematica. My pronouns are he and him. I'm here with my colleagues Leslie, Shannon, Laurie, and Lauren on behalf of our whole evaluation team, and we're here to present findings from our second annual evaluation report for primary care first. This report was recently made public. It's available on the Innovation Center website, and we encourage you to check it out when you have some time. You can also find out some more information about me and the other presenters in the bios that are available. And as I said, we're excited to present these findings, so let's go ahead and jump in. So I'm going to kick things off with just a very brief overview of our evaluation and how it relates to the model before turning it over to my colleagues to present some more of the detailed findings. So like other Innovation Center models, there are two main goals for primary care first. One is to reduce Medicare spending, and CMS expects for this model that will primarily occur through reductions in acute hospitalizations. And then second, there's a focus on quality. Now, our evaluation goals, they align with the model goals. We want to determine the model's impacts on Medicare Part A and B spending and hospitalizations. And these are our two primary outcomes for our evaluation: expenditures and hospitalizations. And we also want to look beyond those two outcomes. We look at a set of secondary outcomes that do include quality measures as well. Now, we don't just want to stop there. We also, part of our evaluation, we also want to understand and describe the model's implementation. So how are all of you in the field implementing the model? What changes are occurring? And we also want to identify the pathways through which we'll interpret the model impacts. So we're obviously want to understand if there are impacts, but we also want to understand how these impacts are occurring. And another goal of ours is to inform policy and help CMS make decisions and improve the model. So for example, there was a recent change in the PECS benchmark, and we were able to provide some information to support CMS in their decision making. Now, to frame the evaluation, we've developed a logic model that represents the conceptualized relationship between the various model components, and I'll go through that briefly here. So first we start with the model inputs, and these are the participating practices and staff. So again, all of you and the fee-for-service beneficiaries that are attributed to your practice. It includes our payer partners, the learning system, the data, and of course the model payments themselves. As we move along our logic model, we next go to and think about the strategies that practices adopt to meet the model goals. And these are embedded within these 5 comprehensive primary care functions that CMS has defined: care management, comprehensiveness and coordination, patient and caregiver engagement, access and continuity, planned care, and population health. And I'll get to those little indented sub-bullets in just a minute. So next along our logic model, we come to this section where we think about leading indicators. And these are measures that signal care delivery changes hypothesized to influence the ultimate outcomes of interest. So for example, if we think about beneficiaries who have multiple chronic conditions, are they filling their prescriptions for those conditions? That would be an example of longitudinal care management. And then along the pathway, we come to our outcomes. And as I mentioned, we have 2 primary outcomes that we're interested in: hospitalizations and expenditures. And here are some examples of secondary outcomes. Now, based on practice performance and where beneficiaries receive their care, the performance-based adjustment and the payment accuracy adjustment will affect the total primary care payment. And that's comprised of the total risk-adjusted population-based payment and the flat visit fees, and then that can be reinvested into those practice strategies. And as we know, with any situation, context matters. And so we consider a whole set of contextual factors, and these can range from where the practice is located, the size of the practice associated with a larger healthcare organization, the COVID-19 pandemic, etc. And now, As I mentioned previously, in addition to understanding what the impacts are, we want to understand how these impacts are occurring. And so to do so, we've developed some detailed clinical change models that we're calling causal pathways that take this overall logic model and create more specific hypothesized links between model payments and supports, and then the outcomes. And so far, we've identified a set of 5 hypothesized causal pathways. And we identified these through talking to practices in the first year of participation. And these emerged as common practices that, or strategies that practices were adopting. As you can see here within the care management function, we have longitudinal care management and episodic care management. And then associated with comprehensiveness and coordination, addressing health-related social needs, behavioral health integration, and specialty referral. And today, throughout the presentation, you'll hear about preliminary findings related to progress along these pathways. And with that, I'm going to turn it over to my colleague Leslie, who's going to talk about the characteristics of the participating practices and the payers.
Thanks so much, John. So as John said, today I'll be discussing participation in PCF for both practices and payers. I will present PCF practices, motivation for joining the model, and the characteristics of PCF practices and the Medicare beneficiaries they serve, and how they compare with other primary care practices in PCF regions. I will describe disparities in acute healthcare use among beneficiaries in PCF practices prior to the start of PCF. Then I will describe the reasons practices have left PCF. I will conclude with a description of PCF payer partnership. At the start of 2022, nearly 3,000 practices were participating in PCF. Using data that practices report on the CMS portal, we found that most practices joined the model to be at the forefront of practice transformation. That's the top set of bars representing more than 1/3 of practices. The second most common reason practices joined was to improve quality of care for their patients, and that was reported by more than 1/4 of practices. Other reasons practices gave for joining PCF included aligning with other initiatives, a decision by leadership, and increasing practice revenue. We analyzed characteristics of practices participating in PCF and those of other primary care practices in PCF regions. Before joining PCF, most PCF practices already had experience with value-based payment arrangements and were different from other primary care practices in meaningful ways. For example, compared with other primary care practices in PCF regions, PCF practices were more likely to be larger, affiliated with a parent organization, meaning they were not independently owned, and were more likely to have participated in a medical home program or another CMS initiative. In 2020, prior to the launch of PCF, about 2/3 of PCF practices had participated in an advanced alternative payment model, and about half had participated in the Medicare Shared Savings Program. Cohort 2 practices were more likely than Cohort 1 practices to have experience with value-based payment initiatives, including higher rates of prior participation in an advanced alternative payment model, and of course, participation in CPC Plus. Before this PCF model launched, Medicare beneficiaries served by PCF practices differed from beneficiaries in non-PCF practices. Specifically, PCF practices served less vulnerable populations who had lower healthcare use. PCF beneficiaries were more likely to be non-Hispanic white and were less likely to be dually eligible for Medicaid and Medicare or eligible for the Part D low-income subsidy. PCF beneficiaries also had lower total Medicare expenditures, lower acute care use, and lower primary care use. But among PCF practices, there were some notable differences in their Medicare populations. For example, practices in Cohort 2 and practices that previously participated in CPC Plus served healthier beneficiaries, such as those with fewer chronic conditions, who had lower Medicare expenditures than Cohort 1 practices or non-CPC Plus participants. Within PCF practices, we looked at disparities in acute care use across beneficiary subpopulations in the 2-year period prior to the start of PCF. Acute care use refers to acute hospitalizations and emergency department visits. In subsequent evaluation work, we will assess the extent to which PCF affected these disparities. In our baseline analysis, we found that the highest rates of acute care use were among the more socioeconomically vulnerable subgroups. The graph shows the relative difference in acute care use between beneficiary groups in percentage terms. On the left is acute hospitalizations, and on the right is ED visits. The first 2 rows of this graph show that beneficiaries who qualified for the Part D low-income subsidy and beneficiaries who were dually eligible for Medicare and Medicaid had rates of acute hospitalizations that were 75% higher, that's the left column, and rates of ED visits that were 90% higher, the right column, than beneficiaries who were not dually eligible. We see a similar pattern across race and ethnicity in the bottom rows. Black beneficiaries have a higher rates of acute care use, and Hispanics have higher rates of ED visits compared to non-Hispanic whites. What's driving the higher acute care use among the more vulnerable beneficiaries? Well, the types of visits are influenced by access to high-quality primary care. For example, disparities were large for potentially preventable hospitalizations and for types of ED visits that could be substituted with primary care. Prior research suggests that primary care initiatives may have more impact on these types of acute care use. This means that PCF could influence disparities in acute care use across beneficiary groups over the course of the model. Now, let's shift gears to practices leaving the model. By the end of 2022, almost 30% of Cohort 1 practices had withdrawn from the model since starting PCF in 2021, and 10% of Cohort 2 had withdrawn since starting the model at the beginning of 2022. For practices that withdrew in 2022, over 70% did so voluntarily. Over 40% of Cohort 1 practices that withdrew cited as the main reason as withdrawing their concerns with the payment accuracy adjustment, formerly known as the leakage adjustment, which applied only to Cohort 1 in 2022. That's the top dark green bar in the graph. For Cohort 2, the most common voluntary reason for withdrawing was to join ACO REACH, another CMMI model. That accounted for about a third of withdrawals, and that's the non-solid shaded green bar in the second row. We don't show involuntary withdrawals, but for Cohort 2, the requirement of meeting a minimum beneficiary threshold was an important reason why practices exited the model. Now I will describe payer partnership in PCF. As with other primary care models, CMS encouraged payers such as commercial insurers, Medicaid agencies, Medicare Advantage, and health insurance marketplace plans to develop a PCF-style payment model to encourage broader primary care transformation. In 2022, PCF had a total of 23 payer partners. In this map, we show the number of payer partners by region, with darker shades of green indicating more payer partners in the region. Nearly all PCF regions had at least one payer partner. However, most regions had only a single payer, and that's the lightest green in the figure. Further, in many cases, the payer partner was a national payer such as Humana or Aetna that took an overall national approach to payer partnership. For example, before Humana departed the model at the end of 2023, instead of having regional representation for each participating region, 1 to 2 staff members represented their entire PCF partnership. Humana did not modify their approach for PCF based on regional needs. These patterns limit the extent of payer partnership and collaboration compared to CMS's vision of PCF. How is this information on payers relevant to PCF practices? CMS asked payer partners to align with the CMS payment approach, hypothesizing that this would reduce practices' administrative burden and create stronger incentives for practices to invest in care delivery changes. The CMS payment approach included full primary care capitation and upside and downside performance-based adjustments. Half of the payer partners provided alternatives to fee-for-service payments and provided performance-based adjustments. However, only 2 payer partners offered a payment model that aligns closely with CMS's payment approach in terms of full primary care capitation and both upside and downside performance adjustments. Payer partners reported barriers to offering a PCF-aligned payment approach were a lack of practice readiness and willingness for capitated payments and downside risk. These factors could be a barrier to implementing an aligned payment model and could limit the extent that PCF influences practices' care delivery, at least relative to how CMS envisioned the model. I will now pass it along to Shannon, who will discuss PCF payments. You're also going to see questions in the chat related to my presentation that you're welcome to answer, and you'll see these at the end of each section. So, thank you.
Thank you, Leslie. My name is Shannon Heitkamp, and in this section, I'll describe how the payments and supports practices receive under the PCF model, including how practices experience them. So in this section, I'll describe the model payments, including how they compared to fee-for-service, and how practices experience the payments, including their impressions and experiences with the performance accuracy adjustment, or PAA, which is formerly known as leakage, and the performance-based adjustments, or PBAs, in 2022. So including an estimate of the performance accuracy adjustment, or PAA, PCF Cohort 2 practice revenues remained, on average, 33% greater than what they would have received under fee-for-service. These findings are consistent with our analysis of the Cohort 1 payment comparison, which found that PCF model payments were almost $7 per beneficiary per month higher than traditional fee-for-service. Because Cohort 1 practices received a positive performance-based adjustment, or PBA, of about 7% in 2022, this suggests that the PCF payments might be even higher compared to those with fee-for-service payments, because that positive adjustment is not accounted for in this calculation or in the graph you see on this slide. When comparing across practice risk groups, the difference between PCF and fee-for-service payments is higher among higher risk groups. These differences are driven by larger population-based payments for the higher risk groups because of the higher average acuity of the patients they serve. Specifically, payments under PCF, including the performance accuracy adjustment, are on average 29% greater than fee-for-service payments for practices in risk group 1, 57% greater for practices in risk group 2. For risk groups 3 and 4, model payments are more than twice as large than fee-for-service payments, 133% greater for risk group 3 and 164% greater for risk group 4. In our interviews with practices characterize the methodology used to calculate performance accuracy adjustments as unfair and in conflict with their goals to provide greater access to healthcare. CMS designed the performance accuracy adjustment to avoid paying twice for the same service, once through the performance-based payments and to the PCF practice, and then once through fee-for-service payment at another primary care practice. Practices noted frustration that their performance accuracy adjustment included patients accessing care within the parent organization, but outside of their attributed primary care practice, such as using an urgent care or walk-in clinic. Practices also saw the performance accuracy adjustment as unfair because many visits with nurse practitioners who provide specialty care counted as primary care visits and could contribute to the performance accuracy adjustment. And I think this is illustrated well by the quote on the slide. I'll pause for a second for folks to read this. And moving on to the next slide. Among cohort 1 practices, most, or about 62%, received a positive performance-based adjustment in 2022. The performance-based adjustment went into effect for cohort 2 in 2023 and will be reported in the third annual report. This adjustment did not, however, offset the downward effect of the performance accuracy adjustment on practices, which was much more significant. Specifically, although performance-based adjustments increased cohort 1 practices quarterly payments by about 7% on average, or about $14,477, the payment accuracy adjustments decreased cohort 1 practices payments by an average of almost $43,000. In terms of qualifying for the performance-based adjustment, nearly all practices met benchmarks for the ECQM quality gateway measures, but only 70% of practices met the PECS benchmark. In our interviews, practices most commonly identified PECS as a challenge for qualifying for positive performance-based adjustments. These practices criticized the PECS performance of the quality gateway as unfair because they saw them having little control over the low response rates that could result in small sample sizes. And they see the quality gateway as having too high of a threshold. Partly in response to this feedback, CMS adjusted the PECS quality gateway measure starting in performance year 2024, moving a benchmark population of all PCF practices to a static benchmark of 77. Thank you. And I'll now turn it over to Laurie.
Thank you, Shannon. I'm Laurie Felland, and I'll present our findings on the care delivery strategies that practices implemented during PCF to reduce hospitalizations or total cost of care. So I'll start by sharing findings on the prevalence of activities that practices were undertaking in their first year of PCF based on our analysis of portal data. Then I'll give you a closer look at practices' implementation activities and experiences during their second year of PCF based on our virtual interviews with practitioners and staff from a sample of practices. Before I begin, I'd like to thank all of the PCF practices for their participation in our data collection efforts to help us understand these care delivery activities. We know how busy you all are, and we really appreciate you taking the time to share your experiences. In our analysis of the portal data, we found that PCF practices reported making many care delivery changes in their first year of PCF. This suggests that they were actively working to improve care delivery across multiple areas rather than focusing on just one or two. As this figure shows, more than 70% of practices reported making changes in each of the 7 areas the portal questions asked. Many of these changes built upon existing processes in the practice. So practices were really focused on improving what they were already doing. Most PCF practices reported making improvements to their care management processes. In a specific example not shown on the slide, 70% of PCF practices reported that they improved or developed new processes to follow up with patients after a hospital discharge or emergency department visit. The focus on such care management processes aligns with the PCF care delivery requirements. In addition, most practices reported improving comprehensiveness and coordination of care, such as by enhancing behavioral health and referrals to specialists. And most practices indicated through the portal that they were working to engage patients and caregivers in patient care. I want to point out also that we don't know how these care delivery changes compare to what non-PCF practices were doing in these 7 areas. As Leslie noted, compared to other practices in the same regions, PCF practices were more likely to be large, part of a parent organization, and to have participated in a medical home program or another CMS initiative prior to joining PCF. This slide shows that when practices were asked in the portal specifically how they worked to reduce acute hospitalizations, they overwhelmingly reported that care management was their main strategy. This indicates care management was not only an area where most practices reported making changes, but it was also a high priority activity for them. In my next few slides, I'll share more details about what we learned about in our interviews with a sample of risk group 1 and 2 practices about their care management strategies, as well as their strategies related to comprehensiveness and coordination of care. I'll start with longitudinal care management. As a reminder, longitudinal care management refers to providing long-term assistance to patients who have chronic or ongoing health issues or complex needs. This slide shows the 3 main types of changes to longitudinal care management that practices commonly told us about in interviews. First, practices standardize their processes to identify high-risk patients for longitudinal care management. Second, they broadened their criteria for who to include in longitudinal care management. Third, they expanded their teams that provide longitudinal care management. Rather than discuss all of these changes in depth, which we have detailed in our annual report, I'll share a common example. Practices demonstrated greater reliance on data-driven risk scores or quality metrics relative to clinical judgment to identify patients who might benefit from longitudinal care management. They also expanded eligibility, which typically meant starting to include patients based on their health-related social needs or having chronic conditions such as diabetes or hypertension. Some practices describe these changes as giving their longitudinal care management program more structure. And this slide shows the common types of changes that practices told us they made to enhance episodic care management, which refers to providing shorter-term assistance to patients who have a new diagnosis or injury or an acute exacerbation of an existing condition, especially as these patients transition from a hospital or another facility. Many practices refer to this as transitional care management. The changes practices described fell into 4 main areas. First, practices improved their strategies to identify patients who could benefit from episodic care management. Second, they intensified their outreach to and communication with those patients. Third, practices improved access to follow-up appointments with their practitioners. Fourth, they commonly added staff to carry out these functions, or they redistributed other duties in the practice among existing staff so that care managers had more time for episodic care management. Here I'll emphasize that practices improved their access to discharge data from hospitals and other facilities to identify patients for episodic care management, such as by working with those providers to send them alerts through automated discharge and transfer notifications, or by gaining access to their records through interoperable electronic health record systems or health information exchanges. Care managers then reached out to patients more quickly after their discharge to make sure they understood their discharge instructions and that they received their medications and other supports. Care managers more regularly checked in with these patients to monitor their conditions and to address any emerging issues. They also worked to get the patients in for a follow-up visit with their primary care practitioner in a timely manner. Practices set parameters and goals for these steps. At one practice, for example, care managers began contacting patients within 48 hours of discharge and booked them as follow-up appointment within 10 to 14 days. Many practices created the capacity for this more timely follow-up by reserving appointment slots in practitioners' schedules. In the category of improving comprehensiveness of care as a strategy to reduce hospitalizations, practices told us about 4 main activities related to behavioral health and addressing health-related social needs. First, practices screened more of their patients to determine if they had any behavioral health or health-related social needs. Second, they expanded their staff capacity to help address needs identified through these screenings. Third, practices worked with providers and programs in their communities to help patients get the particular services they needed. Fourth, they used their electronic health records more for both screenings and to coordinate referrals and link patients to community resources. I'll highlight here that a key strategy was to screen more patients for health-related social needs and to do so more regularly and frequently. For example, some practices moved away from screening patients in an ad hoc way when they observed a potential need or only for certain patients, such as those in longitudinal care management. And instead, they started routinely screening all patients at least once a year. Adopting newer expanded screening tools and embedding them into the electronic health record supported these efforts. Risk group 1 and 2 practices also worked in 3 main ways to better coordinate the specialty care that their patients needed. Here too, they expanded how they use their electronic health records as a way to communicate with specialists and track referrals to them. Second, they expanded their capacity to support this work by hiring additional staff or shifting work among existing staff. Third, some practices entered into formal collaborative care agreements with specialists that laid out their expectations for seeing patients within a timely manner and for communicating with them about the patient's care. I'll highlight the first strategy. So instead of relying on the phone and faxes to share information about their patients, practices work to interact with specialists more through the electronic health record. For example, new features enabled them to track referrals to specialists to ensure that the visits occurred and to view specialists' notes and records about their patients, and in some cases, even chat directly with specialists and patients. We also interviewed a sample of practices from risk groups 3 and 4. As reported in our first annual report, these practices were already using a high-touch integrated model of care before they joined PCF. In addition to implementing many of the activities that risk group 1 and 2 practices described, risk group 3 and 4 practices also commonly reported making changes in 2 other primary care functions: population health and access to care. I'll highlight ways that practices improved their focus on population health. Many practices scaled up, expanded, or improved practitioner and staff use of dashboards with clinical quality metrics. And a couple of practices rolled out new dashboard platforms to support their quality goals and better identify gaps in care. To then address those gaps, practices described revising their workflows, such as by having medical assistants or other dedicated staff reach out to patients and schedule appointments, or by increasing practitioners' use of reports that highlighted the care gaps among their patients. Finally, taking a step back and looking across all of the practices we interviewed, we identified 6 common factors that affected practices' implementation of care delivery activities during the second year of PCF. First, participation in other CMS models, such as the Medicare Shared Savings Program and Comprehensive Primary Care Plus, as well as Medicaid-sponsored and commercial accountable care organizations, helped lay the foundation for practice improvements under PCF. Practices reported these other arrangements typically aligned with PCF goals and objectives and provided infrastructure for the care delivery activities that they could then continue and enhance under PCF. Second, many of the practices we interviewed were part of a larger parent organization, such as a hospital system or multi-practice organization. These parent organizations typically made the decision to join PCF on behalf of their member practices and then led the effort to implement care delivery changes by providing practices electronic health record enhancements, health data, and staff. Third, although practices received support from parent organizations and additional funding from PCF to support their care delivery activities, they often struggled to find enough staff to meet their staffing needs. Practices attributed these challenges to workforce shortages in their communities, and for some of the smaller practices, to an inability to compete with the salaries that larger organizations could offer. Fourth, practices reported facing a lack of certain types of services in their communities, such as for some medical specialties, for behavioral health, and social services. But they found that efforts to establish relationships with other providers and organizations in their communities helped them connect their patients to these services. Fifth, as is already apparent from the examples I've shared, practices said that robust and compatible electronic health record systems were critical for carrying out their care delivery activities. And finally, some practices said they struggled to engage patients and caregivers sufficiently in the changes that they were making. This was a particular challenge with their patients who were living on lower incomes, who could not afford to pay out of pocket for services, and who faced other barriers to communicating with the practice and connecting with resources, such as inconsistent cell phone service and a lack of transportation. And with that, you should see some questions in the chat to reflect upon in these areas. Thank you. I'll now turn it over to Lauren.
Thanks, Laurie. I'm Lauren Forrow, and I'll be talking about how the implementation activities that Laurie just described, so all the hard work that you all have been doing, have so far translated into program-wide impacts. I'll be talking about two categories of outcomes: leading indicators and primary outcomes. And I'll describe them a little bit more on the next slide. So starting with leading indicators, we have 8 leading indicators that we're studying as part of the evaluation of PCF. And these are measures that describe care changes. We're looking to see whether the care changes that are taking place are consistent with the model's long-term goals. The primary outcomes describe those long-term goals. And as John said at the beginning of this presentation, the long-term goals of PCF are to reduce acute hospitalizations and Medicare Part A and B expenditures. So before I start to share results on these two sets of outcomes, I do want to say just a few words about how we calculated those results. The findings that we're going to share represent the difference between the change over time in outcomes among PCF practices and the change over the same time period among a set of otherwise similar practices that are not participating in PCF. So really our goal is to hone in on the difference that PCF makes to outcomes. Today we'll be focusing on results for the first PCF performance year, which was 2021 for cohort 1 practices and 2022 for cohort 2 practices. This is the first year for which we have data from all the practices, and so we think it provides the most complete picture of the results so far. So I'll start with the early effects of PCF on leading indicators. Overall, we found limited evidence that PCF has led to substantial improvement in leading indicators. There are 2 counterexamples that I'll describe in just a moment, but first I do want to just reiterate that definition of the effects that we're sharing. We're really focused on the difference that PCF makes to outcomes. So when we say there's limited evidence of substantial improvement, we mean we've found limited evidence that being in PCF makes a difference on these dimensions. But as I said, there are 2 exceptions that I want to share with you. First, we found small favorable impacts on 2 indicators associated with longitudinal care management, specifically with medication management. So we found a decrease in the proportion of elderly beneficiaries with high-risk medication use, and an increase in the proportion of beneficiaries adhering to medications for multiple chronic conditions. By contrast, we found a small unfavorable impact on 1 leading indicator associated with episodic care management. We found a small decrease in the proportion of inpatient discharges, emergency department visits, and observation stays with follow-up care within 7 days. But taking all of the results together, we think the overall message is that there have not been substantial changes in care delivery as a result of PCF. And since our focus on leading indicators is supposed to provide context for our understanding of results for primary outcomes, it won't be much of a surprise to you that we also did not find meaningful effects on primary outcomes. Specifically, we saw no meaningful change in acute hospitalizations and a small increase in Medicare Part A and B expenditures. But as Shannon already shared, we have found that PCF model payments are actually more generous than regular fee-for-service. And the amount by which we find that PCF has increased Medicare Part A and B expenditures is very consistent with the generosity of the PCF payments. So taking these things together, we really don't see much of an effect of PCF on primary outcomes at this stage. And this is very consistent with our hypotheses. We would expect that it will take a long time for care delivery changes to translate into outcomes. So we look forward to continuing to gather more data, evaluate the effects of PCF, and of course, hear your feedback on the questions that will shortly be appearing in the chat. And so with that, I'll hand it over to John to talk about next steps for the evaluation.
Thanks, Lauren. So I'll be just spending the next few minutes talking about next steps and wrapping things up. So as we've heard today, we've had some preliminary estimates of PCF's impact, and what we want to do is strengthen our estimates going forward. So our first step is to refine our comparison group for future annual reports. And the other thing we're going to be doing is expanding the set of outcomes and subgroups that we're looking at. So for example, we'll be adding additional outcomes that we think the model may affect. All-cause ED visits, for example, potentially preventable hospitalizations and total primary care visits. And we'll also be adding additional subgroups. So for example, beneficiaries who are dually eligible for Medicaid and Medicare. Now, as we've heard, we know practices have been leaving the model, and we want to understand the effects of the model on the set of practices that continue to participate. So we'll be looking at that as well. Now, some specific data sources and analyses that will be new for our next annual report include the following. We'll include results from a recently completed practice survey, and we'll examine the effect of nurse practitioners on the payment accuracy adjustment. So we heard about that earlier, looking at that relationship there. And then we're also going to take a look at the relationship between the performance-based adjustments and the practice level reductions in acute hospitalizations. So see how that relationship works between the money that is delivered through the performance-based adjustment and then the actual impact on the hospitalization reductions. And then looking beyond the next annual report, later this year, we're going to be interviewing a set of high-performing practices about the factors that they believe are driving their success, and that will be included in not this next annual report, third, but the following one. And then we'll also be talking to beneficiaries in 2025 to get their perspective on the model. So with that, I want to thank all the presenters, thank our entire evaluation team, and thank all of you for all the hard work and attending our session. Thank you.